To understand how a brain loses its ability to communicate, we have to distinguish between two distinct pathologies, a stroke and a traumatic brain injury. A stroke typically produces a focal lesion. Because the tissue damage is localized, it creates classic aphasias, specific losses in linguistic domains like vocabulary retrieval or syntactic structure. Traumatic brain injury operates differently. Instead of a localized pocket of cell death, it triggers a massive, widespread disruption of the brain's structural networks. This widespread degradation results in a distinct clinical condition known as a cognitive communication disorder, or CCD. Unlike patients with classic aphasia, individuals with a CCD often retain their foundational linguistic tools. Their grammar is intact, and their vocabulary is preserved. The breakdown occurs in the interactional use of that language. The underlying cognitive architecture required to deploy words in a social context has collapsed. A successful diagnosis moves beyond traditional aphasia models to first account for the biomechanical physics of the head trauma. Mechanical forces in TBI fall into two primary categories: open, penetrating injuries, and closed, non-penetrating injuries. Closed head injuries are frequently driven by linear acceleration, where a force is applied along the midline of the head, propelling it in a straight line. For a few milliseconds after impact, the brain remains still due to its own inertia, while the skull rapidly accelerates. This creates the coup injury. As the skull moves, the anterior of the brain compresses against the interior bone. When the skull stops, the brain's momentum continues. It rebounds and impacts the opposite side of the cranial vault, causing a secondary counter-coup injury. During this shift, structures at the base of the cranium rub against sharp bony projections. The inferior margins of the frontal and temporal lobes are highly susceptible to this specific tissue abrasion. Linear acceleration causes severe, localized cortical and meningeal damage, but these focal injuries alone do not explain the systemic communication breakdown seen in CCDs. The true engine of cognitive collapse is angular or rotational acceleration. This happens when a force strikes the head off-center. As the head rotates away from the blow, the brain twists inside the skull, generating massive internal structural tension. This violent twisting and shearing of neuronal interconnections is called diffuse axonal injury, or DAI. DAI devastates the brain's primary communication tracts, specifically targeting the corpus callosum, the brainstem, and the frontotemporal white matter. Clinicians grade this damage from 1 to 3 based on the depth of the lesions and how widespread focal abnormalities appear in these specific white matter structures. While a stroke causes immediate, localized tissue death, DAI initiates a process of delayed axonal disconnection across entire hemispheres. The resulting physiological outcome is a severe malfunction of the pathways connecting the frontal lobes to the rest of the brain. This diffuse neurocellular disconnection is the biological driver of the cognitive collapse that causes pragmatic communication failure. To see how this cellular damage cascades into observable deficits, we have to look at the brain's memory systems. This data highlights a sharp divide between implicit procedural memory, which handles motor and cognitive skills, and explicit declarative memory, which stores autobiographical facts and events. Because they rely on different structures, procedural memory often remains intact, while explicit episodic memory is highly vulnerable to diffuse axonal injury. Working memory is the critical active component. It relies on the central executive to manage information in real time during a conversation. The phonological loop holds acoustic and linguistic information temporarily, allowing for the processing of a continuous flow of speech. When these systems fail, patients repeat ideas, lose track of instructions, and struggle to use compensatory strategies. Clinicians use post-traumatic amnesia, a temporary state of continuous memory failure, as a primary metric to classify the initial severity of the TBI. Without functioning working and episodic memory, a patient loses the context required to maintain a coherent narrative or social role. Managing these systems requires a meta-layer of cognition, known as executive function. Foundational executive processes, inhibition, working memory updating, and cognitive flexibility form the base of this hierarchy. These core mechanisms feed upward into higher-order functions like reasoning, planning, and problem-solving. Ultimately, these processes enable metacognition, allowing an individual to regulate their behavior and maintain self-awareness during dynamic interactions. The social communication model maps executive function as the central link between cognition, language, and social-emotional processing. When this link is broken, discourse becomes overly concrete and socially insensitive, despite the patient's preserved vocabulary. Behaviors like inappropriate topic switching are direct manifestations of a breakdown in executive inhibition and mental set shifting. This behavioral collapse traces directly back to the diffuse white matter damage caused by rotational acceleration. The CCD phenotype is a systemic failure of the executive system to appropriately command linguistic tools in a social environment. Assessing executive function post-TBI introduces a significant hurdle known as the task impurity problem. Executive function cannot be measured in a vacuum. Every target process must be embedded within a specific task that requires subordinate skills like vision, motor speed, or language to function. If a patient fails a verbal fluency test, the clinician must distinguish whether the failure stems from a frontal lobe executive deficit or temporal lobe linguistic failure. Comprehensive testing batteries like the DCEFs attempt to isolate these variables by mapping specific subtests to core and higher-order processes. It uses conditional baseline tasks to rule out fundamental cognitive deficits before measuring the target executive process. A patient might pass a memory screening in a quiet clinic, yet fail entirely when trying to process information in a demanding workplace. To achieve true ecological validity, clinicians utilize the World Health Organization's ICF framework. This model starts with body function and structure, linking cortical damage to cognitive impairment. It then moves to activity limitation, measuring reduced effectiveness in functional tasks. Finally, it measures participation restriction, evaluating the loss of autonomy and social roles. Traditional aphasia models often stop at the impairment level, missing the activity and participation failures characteristic of traumatic brain injury. The clinician's objective is to merge neuropsychometric data with direct observation to map a recovery plan for daily living. Rehabilitating cognitive communication requires reconstructing the patient's executive autonomy rather than simply correcting the syntax of a sentence.